Welcome to the Oral Surgery Fight Club podcast. This is a collection of mock cases in the field of oral and maxillofacial surgery in a question and answer format conducted on Zoom. Enjoy.
Oh, there's a good amount of people.
Let me share my screen here.
Hmm.
Are you at your parents' place, Greg?
Yeah, childhood bedroom.
That's awfully cool, man.
Yeah.
All right. So what do we got today? We got dental alveolar, huh? Albana, our cases might overlap just because I didn't figure out what you were doing, but I did something similar.
Yeah.
Anyway.
Okay, cool. No worries.
Dental alveolar should be straightforward, though. Again, it's an exam of what would you do. As long as you stick to what you would do, like most everybody is going to pass on the dental alveolar section, unless you're, suggesting some ridiculous things, which maybe I'll push Greg into here, but we'll see.
Okay.
All right, 902. Okay, so you get a 12-year-old female, walks in your office. Your assistant already took a panoramic x-ray, but she's referred to you for some impacted teeth. She doesn't have a past medical, surgical, social, no meds, nothing like that. Can you describe what you see here?
Sure. So this is a diagnostic panorex. Patient is has full complement of maxillary teeth, impacted 11 and 6, coming around. Seems like lost or congenitally missing number 20, and delayed eruption of number 29. Patient has a lingual holding arch as well.
Yeah, sure. So when do the canines typically erupt?
Maxillary canine somewhere in the 11 to 13, depending on the patient's dental age. Mandibular a little earlier.
So the patient and their mother don't really want, they don't want to even talk about surgical options. They're sort of asking you if they can wait some amount of time for these things to erupt.
I would like to obtain additional imaging, but I would be highly motivational to address these, as it's actually a little late to have them not erupt yet. And I explained to the patient that, these teeth, when not coming in properly, they can actually do a lot of damage to the other teeth.
Sure. How would you assess where they are in the mouth? Let's say your cone beam CT, your assistant tells you, cone beam CT is down, doc. We
Sure.
can't get one.
There will often be a bulge, either on the palatal or on the buccal, that you can kind of use to triangulate the teeth. If that's unclear, you can either take an occlusal film or multiple periapicals. Use the slob rule to orient them.
What is the slob rule?
So it's effect of the window of the radiation exposure. If you slide the collimator of the X-ray over in a certain direction, if you go in that same, if the tooth moves in the same direction on the film, it's on the same side. It's the lingual to whatever the other things are in the image, and if it goes in the other direction, it's buccal.
So let's say you take those images and you determine that these teeth are actually labially displaced. How does that affect your surgical plan?
So, depending on the height, it just determines which side you're going to approach these from. Generally, if they're impacted on the buccal, it's more of a crowding concern. So I would make sure there's enough space pre-operatively. Talk to the orthodontist, make sure we're on the same page about how we're going to expose these, and whether they want the chain or some people want a spring, etc.
The orthodontist says, if you can get this tooth to just erupt, uh, that'd be preferred. Is there any way we could do it without a bracket and chain?
I would say no for a buccal.
Okay. The orthodontist also asks you, what kind of flap design are you thinking?
So these look to be up near the apices of the lateral incisors, but obviously I'd have other X-rays to make sure. Most likely I would have to do this as a closed approach, just because of the degree of I guess the height of how high they are up. So I would do a full thickness mucoperiosteal flap, expose the teeth, remove follicle, place buttons on both of them.
How far do you remove bone?
Just up to the CEJ, no further.
Do you luxate the tooth when you do this?
I don't, for routine.
What materials do you use?
I use insert orthodontic adhesive that I forget what it's called. But I'll use an etch, primer, and I use a light cure. Some people use glass ionomer, but that's not what we have in the office.
Let's say you expose the tooth and things just keep bleeding around it. You can't isolate it, and your assistant is not really your assistant. Your main assistant is out that day, so you have just a temp who doesn't really. She can't isolate the field very well for you.
So in the past, I've either taken a gauze and packed it around the crown of the tooth, or take a cotton roll, rip up, soak it in local or vasoconstrictor, and you can kind of pack that around the crown of the tooth to help with hemostasis, as long as you count the little pieces so you don't leave anything behind.
So you managed to do that. You isolate the tooth. What material are you using to secure the bracket?
Yeah, that's the one I forget. It's an adhesive,
okay.
light cure adhesive.
Okay. Your assistant actually tells you at this moment you don't have any brackets. She asks you and also tells you that at her last practice, the oral surgeon used a circumdental wire. Would you use a circumdental wire?
No.
Why not?
It can cause resorption of the root. It can cause bone loss around the crown of the tooth. It's just no good. I would, if I have just a standard orthodontic bracket, I would probably use something like that instead, if you have those around the office.
Sure. So that patient ends up leaving. You're going to do the procedure another day. Okay. Your assistant tells you you're getting a call from a potential referring dentist. You've worked really hard to get this guy's business and take care of his patients along with him, but he says he does a lot of oral surgery and TMJ stuff himself. He says he did a nice residency, and he'd like to speak to a fellow expert such as yourself. He has several questions about a third molar he's about to take out.
Okay.
He says, what are some of the possible complications I might see from an IAN block?
So IAN block, you can lead to obviously paresthesia, hematoma, infection in the pterygomandibular space. You can get broken needle, and
he goes, Doc, I'm not saying I've done it, but I had a close friend who broke off a needle in the somewhere in the muscle there. How would I get it out? Saying if I did break a needle off.
So I think it's unlikely for you to be able to identify that yourself, but at least
He goes, no, I can identify it. I was trained in oral surgery.
you can take a CBCT to see where it is, but personally, I would rather involve like a interventional radiology group at a hospital because I'd be afraid me pushing it deeper into the space, blindly looking for it. So they'll use fluoroscopy to find it and grab it.
He doesn't like the idea of referring the patient out. He says, is there? He thanks you for your time, and he does all he can for the patient. And the patient arrives in your chair 3 hours later. The patient, is in a considerable amount of pain, and he calls you up again saying, I got most of the crown out. Don't bill the patient for this, but could you handle this? Managed to get the following X-ray. Can you describe what's there?
Looks to be partially extracted wisdom tooth that was full bone impacted. It looks to be removed completely below the CEJ, although I'm not 100% sure what's going on the mesial there, but looks like just kind of the root remains.
Yeah.
I would probably, before getting involved, call the dentist again and just get a little more information about the preoperative situation, whether there was an abscess present, whether there was caries to the pulp on the tooth, anything like that.
Yeah, he says, the tooth wasn't really infected. She didn't have symptoms. It just looked like a third molar I needed to take out. I got most of it out, but usually I don't lay flaps for this. I don't really need to. I'm just very comfortable taking out third molars. It's just this one I need your help with. Don't bill the patient.
Sure. Is the patient still numb?
Yeah, the patient's. She says her lower lip and chin is kind of tingling.
Okay.
She's also shaking in your chair. She's very traumatized.
I think, I would probably, as long as the patient's vitals are stable and they're, willing to proceed while the patient has some local on board, I'd probably give a little bit more local, and just make sure that all the enamel has been removed.
When you go in there, you don't see a root tip.
No root tip? Okay.
You don't see it.
There's nothing left from the tooth?
You don't see it there.
Then I would probably just take another image to make sure.
So you get a cone beam.
Oh.
This is what you see. Your assistant also says she's seen a lot of these at her last practice.
Yeah. At this point, I'd have a conversation with the patient, explain to them that a root has been displaced into the submandibular space, and I would examine the patient, see if I can palpate this. Sometimes you can actually reorient it into the socket enough to grab it manually.
Mm-hmm. So that's unsuccessful when you try that.
Again, I would kind of run two options by the patient. If I felt that I had a good grasp of where it was, I would probably recommend, with understanding that there is a risk to the lingual nerve, to tunnel down on the lingual, separate a little bit of the mylohyoid and grab the root intraorally, versus if the patient was kind of over it, I would probably just let things fibrose.
How long would you let it fibrose?
Honestly, I'd probably wait like 3 to 6 months, and then go in and get it.
So patient likes that option. It's a great thing. You managed to get the root tip out through an intraoral method, but on follow-up a week later, the patient reports she still has tingling of the lower lip and chin. How would you evaluate that?
So I would start with level A, B, C neurosensory testing to determine the degree of injury, fine touch, all the way to, temperature, etc.
What would your follow-up be, like weekly with that ABC?
So I would start, the first couple every week, just to make sure the patient knows that they're being prioritized, and also probably give them a steroid the first week, get them on some vitamins, B complex, monitor them closely, monitor any changes, and then after like the first few weeks, maybe give them a month, and at 3 months, follow recovery. At 3 months, I'd probably start talking to them about seeing a specialist if there are continued neurosensory issues. Maybe get an MRI and send them over to the local nerve guy.
At what point would you want to send them to the nerve guy? How long?
I think with lingual nerve, probably like 3 months.
The patient in the middle of all this follow-up asks you, "Hey doc, could I sue my dentist for this?"
I would tell the patient that as a rule, I don't discuss these kind of things with patients.
No, she really wants to discuss it, and she asks you.
That's not my place, unfortunately. I'm here to, help you get through this trial of a situation, but I just can't get involved in that kind of stuff.
All right, that's the case.
All
right. I was kind of messing with you there at the end, but
no, I know.
that was a fair case.
Yeah, I should have gotten the cone beam before I went into the wisdom tooth site, though. I know that.
Oh, I think from the beginning you did all the right things. I mean, you had everything. The canines, usually erupt somewhere between 11 and 13. I think with the position of these.
I swear, in Queens it's 10 to 12, but yeah.
Yeah. Some populations it's different. Different.
Ryan.
Yeah. What's up?
Hey, with the litigation question, I mean, that's something obviously that might come up in like the ethics portion. My question is like, is it fair to do what Greg says? Like, I don't discuss these things with patients, or would you? Are you kind of does it behoove you to actually address the problem? And that, you weren't there for the surgery.
Yeah. What's up, Luke? I didn't know you were in here, man. It's good to see you.
I'm back, baby. I'm back. Good to see you too.
I think it's just, what would you do? Like if they were there in your clinic, I mean, you wouldn't say, sue the shit out of them. You'd probably tell them, look, it's not my business. Like I know what the situation was when you got to me, and we handled that as well as we could. Any matters that you want to discuss, like, you should take up with him directly. I'm not at liberty to speak about it. On the exam, you're one of the sections. I think it's like a fast.
Hey yo. I gotta sharpen my swords for the oral boards. I learned them from Patel, and he's the Lord. And I'm his protege. You know I'm gonna slay all these motherfucking questions today. Cause I got the sound bites. They're gonna make these old men go, ooh, ah, like some afternoon delight. Yo, I got these questions in my sight, and I got the answers. Yo, my answers is so ill, they give you canker sores.
Thanks for tuning in to Oral Surgery Fight Club. For uncut episodes and sound bites, go to osfightclub.com.